here was included in our research. So it consists Canada, whose native language was English or French from the Indo-European language family, and then 8 subjects from UCSF in the USA, whose native language was English, and 150 subjects from French. Their native language was French, and more than 250 cases from Shanghai Huashan Hospital in China, whose native language is Mandarin from the Sino-Tibetan language family. During direct electrical stimulation, all of the positive sites were marked with sterile labels, and the intraoperative photos were taken to plot the positive sites onto the individual surface post-operative according to the landmarks, anatomical landmarks. Positive sites from all individuals was aggregated into the standard brain template 152. We can see the different centers applied various templates from the results. On the handout template from MNI, we relabeled the positive sites to MNI template 152 according to the anatomical landmarks. And the UCSF team usually use the Calling 27 template, and we use the SPM normalization algorithm to project the positive sites from the template MNI template Calling 27 to MNI template 152. Finally, all speech arrest sites was labeled with reference to the anatomical landmark on the right. You can see here Fig A to Fig D shows the distribution of speech arrest sites in the 4 medical centers, and in Fig E, we present the percentages of speech arrest sites in various brain regions. We can see that in each medical center, the ventral percentile gyrus has the highest proportion of speech arrest sites. In contrast, the proportions in the pars triangularis and the pars orbicularis are relatively low. Finally, Spearman's correlation analysis shows that speech arrest sites have similar distribution pattern across 4 medical centers, and the pairwise correlation coefficients range from 0.2 to 0.85, which is statistically significant. Then we merged the data from 4 medical centers and produced the density map and the cluster map based on the cluster analysis. The bar graph on the left shows the density distribution of speech arrest sites on various brain regions in each cluster. The density map in the middle shows that the peak point of speech arrest is located in the ventral part of percentile gyrus, rather than the traditional Broca's area. And the cluster map shows the speech arrest sites can be divided into 4 parts, and the cluster 1 in the percentile gyrus, and also some area on the pars orbicularis, and the second cluster in the posterior percentile gyrus, and the third one in the supplementary motor area, and the fourth cluster in the posterior temporal gyrus. That means close to the Wernicke's area. Our study highlights the critical role of ventral percentile gyrus in speech output function, and our research supports the notion that the Broca's area is not speech output center, provides evidence for the language functional connectome. Furthermore, the pattern of speech output maps are similar across 3 languages, Mandarin, English, and French, providing evidence for common network across languages. Finally, we believe the work can provide a high-level evidence-based guideline for defining functional boundary of the speech output cortex for clinical neurology. So this is the first step of our research, and the second step, and the results is published on the Brain 2021. And the second research is about the subcortical language pathway, the dorsal language stream. So the results published on Neurosurgery as a cover image paper. So the scientific question derived from the previous study, as I mentioned before, is what is the subcortical structure basis of the speech output center? Since previous studies have shown that the acute fasciculus and the third part of superior longitudinal fasciculus are the major white matter pathways subserving human speech output, we wondered how consistent the frontocortical endpoints of acute fasciculus and the superior longitudinal fasciculus part 3 are with the direct electrical stimulation-induced speech arrest sites. To address these questions, we conducted a large sample retrospective study to revisit the human speech output, speech production network. We selected 75 cases with complete DTI, tractography data, and reconstructible acute fasciculus and superior longitudinal fasciculus part 3 from a pool of total 386 glioma patients as group 1. And after excluding the impact of the tumor and the paratumor edema and simulated the cortical functional distribution of a normal population, we further filtered 26 patients, glioma patients as group 2, whose glioma or edema or peritumor edema did not affect the broadcast area, ventroplacental gyrus, and the corresponding subcortical fiber pathway. Finally, we conduct additional acute fasciculus and superior longitudinal fasciculus 3D reconstruction from 192 normal subjects from our data pool. We utilized 3 ROI masks to extract AF, acute fasciculus, and the superior longitudinal fasciculus part 3. ROI 1 was defined around the posterior temporal lobe here on the axial view, capturing acute fasciculus bundles entering the temporal region. RI3 was determined on the sagittal view around the inferior parietal lobe, comprising the triangle and the angular gyrus and supramarginal gyrus. So for RI3, RI2, we encircled the whole ventroplacental gyrus, broadcast area, Broadman 44, 45, and inferior frontal gyrus on the sagittal view to preserve the frontal termination as more as possible. Subsequently, we calculated the sensitivity, specificity as a statistic analysis. We found a certain degree of individual variation in the frontal endpoints of acute fasciculus and superior longitudinal fasciculus part 3. For instance, subject L1, this one, you can see the fiber bundles terminate at the ventroplacental gyrus rather than the broadcast area, while subject L2 was this case, so you can see the acute fasciculus and SL part 3 terminate not only at the ventroplacental gyrus but also at the pars orbicularis of the broadcast area. However, despite individual difference in this fiber structure, both at the individual and the group 1 level, the endpoints of acute fasciculus and superior longitudinal fasciculus part 3 showed a high consistency with speech arrest sites. After eliminating the influence of the tumor and the paratumor edema, we 3D reconstructed the direct electrical stimulation functional map for 26 subjects to simulate the functional distribution of the normal population. We observed the functional gradient from the higher level lexical and semantic processing to the lower level speech production and articulated mode and sensory function from the broadcast area to the ventroplacental lobe. Additionally, we identify a functional division in the ventral placental gyrus, while the anterior bank are mainly associated with speech arrest site, and the posterior bank are preliminary related to a lower level articulation, motor function, and anomia site. So you can see different bank for the different language production function. This is articulated sensory in the posterior central lobe. So in this large example, normal subjects 198, the endpoints of acute fasciculus and superior longitudinal fasciculus 3 were preliminarily distributed in the anterior half of ventral placental gyrus. Additionally, the IOI curve areas indicate that the endpoints of acute fasciculus and superior longitudinal fasciculus part 3 effectively predicted the speech output area in group 2. So, in conclusion, there are 3 key findings. The first one is the majority of speech output center located at the ventral placental gyrus in red, a gradient functional distribution from high level to level, that means from lexical, semantic processing, from then the speech output center, then the motor articulation, and finally, here in yellow is the sensory articulation function is found in this map. And the second key finding is the dorsal stream, the acute fasciculus, superior longitudinal fasciculus part 3, mainly converged in ventral placental gyrus rather than classical broadcast area. The anterior termination of acute fasciculus or superior longitudinal fasciculus part 3 converged at the ventral placental gyrus in both patient and healthy controls. And the last finding is, suggests a convergence between the cortical function and the subcortical and the subcortical connectivity in the left ventral placental gyrus, as shown on this image. Of course, we need more work. We need more work to answer these more questions. In addition, unpublished data suggested that the acute fasciculus and the superior longitudinal fasciculus part 3 may have similar terminations in both English and Chinese-speaking population. This is unpublished data. So there are also some limitations in our study. For example, some speech arrest sites could be elicited due to the contraction of laryngeal movement. And the accuracy of DTI tractography could be compromised by tumor mass effect and the peritumor edema. And finally, the volume of tracts could be underestimated, especially for long association fibers. So I believe there are more questions to be answered in the future work. We still should step forward. So I do appreciate our international colleague team from different parts of the world. If you have interest to compare with Portuguese and the Chinese and the French and some other language, please keep my email address. We can contact with each other. Thank you so much. Obrigado.
Thanks for brilliant talk, Professor Xix Congresso. Agora vamos para a nossa quinta aula. Eu queria convidar o Dr. Jorge Moura. Então, Dr. Jorge Moura atualmente é professor de neurocirurgia do Instituto Ansejo de Santiago, no Chile. Ele vai apresentar agora O tema Extradural Mini Temporal Mi Plata for Tumoral and Vascular Lesion. Obrigado.
Bom dia a todos. Muito quente aqui, hein? Aqui não. Vamos aguardar um pouquinho para que não se nos dá. Não dá. O problema que eu tenho é que minha tomada não dá para essa que vocês têm aqui. E eu voltei a providenciar uma, mas eu cheguei 6 horas da manhã, então não deu. E o mais improvável é que a computadora vai desligar, então não quero que aconteça isso. Eu primeiro quero agradecer ao comitê organizador. Para mim vocês sabem, uma grande honra voltar sempre para o Brasil. O Brasil para mim é muito importante, é minha casa também. E hoje eu vou falar para vocês uma coisa que me apasiona bastante, que é falar do Mi Plata. Alguns de vocês já conhecem um acesso que a gente está desenvolvendo há um tempo lá. E eu vou tentar falar em 20 minutos. Quanto que é? O tempo 20, 15, 10, 5, 15, 12. Nossa Senhora, tem que falar rápido, tá? Fica difícil falar português rápido, mas vou tentar. Então, agradeço muito a professora que também na mesa. E o que eu vou falar é uma variação de um acesso que foi descrito no 2007 por professor Everval do HC, Universidade de São Paulo, quando ele ficou no Barrow, em Phoenix, com o professor Spetzler e Peter Nakagi. Eles desenvolveram um acesso que é uma variação do acesso arterial, que é um acesso que é menos invasivo, né? É um tipo de cirurgia que faz que seja mais reproducível, mais eficiente, menor atrofia temporal, um monte de coisa. E que tem muita crítica porque poderia ser que o acesso menor fizesse que uma cirurgia mais complexa não fosse possível. E a filosofia nossa é todo o contrário. A complexidade da cirurgia não tem nada a ver com o tamanho da craniostomia. Tá bom? Então, assim como em coluna, o acesso à coluna, ninguém vai começar a brigar que ha ido diminuindo, não? Quando eu fiz a residência em neurocirurgia, a gente abria assim a coluna. E agora abrem um buraquinho e fazem uma hernia do disco por endoscópio. Tá? Não sei nada. E esse é meu conflito de interesse. Eu sempre agradeço ao professor Evandro. Eu fiquei com ele no ano 98 por um ano, e também com Euder e Wen. Eu sei que muitos de vocês conhecem a eles. Euder é um grande neurocirurgião, trabalha em Campinas, e Wen era por muito o melhor fellow que tive em Rotten, e trabalha no HC. Eu dei para mim de presente este slide, essa dissecção que ele fez da parede lateral do seio cavernoso, e eu tenho essa foto desde 1998 e nunca vi a verdade que tem aí na foto. Em 12 minutos não posso explicar para vocês, mas o acesso transcavernoso que fazia o Dr. Evandro, Alicris, Dolenk, é um acesso pelo teto do seio cavernoso. Tá? Que basicamente é feito para anemia aracnoide, topo da basilar, lesões como adenoma de hipófise, etc. Mas se vocês usam a parede lateral do seio cavernoso, vocês podem ver aí que entre o quadrilátero de Kawase e a clinoide posterior você não tem nada. Então você pode chegar até a fossa posterior. A gente publicou isso daqui no ano 2021, E a filosofia nossa, aí vocês veem na dissecção que é a cirurgia de dolente, e na frente da cirurgia nossa, que é um acesso mini-terional extradural. A gente descreveu esse acesso no 2020, e este daqui é uma variação do acesso mini-terional extradural. Por quê? Porque quando você usa o corredor extradural, você consegue ter uma muito melhor visão da anatomia. Eu vou mostrar para vocês um caso muito simples, que é um piloto de avião que tinha um meningioma esfenopetrocrival. Meningiomas esfenopetrocrivais são muito complexos, porque são meningiomas do seio cavernoso, petrocrival e fossa média. Então o meningioma não era muito grande, mas este doente tinha neuralo de trigêmeo e tinha terceiro nervo. Tá? Então, aí é a importância da cirurgia. Por quê? Porque normalmente a maioria das neurocirurgiões pensam que quando um doente tem terceiro nervo tem que fazer radiocirurgia, porque a cirurgia só piora o nervo craniano. Isso não é verdade. Se você faz uma cirurgia para liberação do nervo craniano, você tem melhora. A gente tem publicado isso, não estou falando uma coisa que não está publicada. Então aqui você vê as dissecções da anatomia feitas no laboratório do Dr. Rotten, onde está mostrando a dissecção extradural. E se você vê aí a cirurgia, é uma anatomia mini-terional do lado esquerdo. Aí vocês veem como a gente usou um ponto para puxar o gramater. Depois disso a gente faz uma clinectomia anterior extradural, sempre extradural. A clinectomia anterior subdural é para patologia vascular. Para a patologia tumoral, você precisa fazer extradural para a descompressão da via óptica. Depois disso a gente abre a dura mater, muito pouco, só na zona onde você vai tirar o tumor. Depois disso faz a liberação sequencial do óptico, da carótida, terceiro nervo, quarto nervo e trigêmeo. Tudo aquilo é possível. Eu quero que vocês vejam, eu posso estar mentindo, não? Falar que me não, estou mentira. Mas você tem que acreditar em mim, tem que acreditar seus olhos, vocês estão olhando aí o vídeo que eu estou mostrando. Tá? E aí estou tirando o tumor, a retração do lóbulo temporal é muito pouca retração. Por quê? Porque a cirurgia é feita por um corredor extradural. E a porção que você usa do vaso crânio é muito pequena. Então ali a gente está liberando o terceiro nervo, libera completamente o terceiro nervo. É uma cirurgia diferente porque a filosofia de Dolenque e de todo outro neurocirurgião que faz seio cavernoso, eles liberam de cisterna a seio. Eles liberam de seio a cisterna. É o contrário, porque é muito mais seguro e melhor. Ali a gente já tem o terceiro nervo liberado. Olha a compressão que tinha o terceiro nervo, igual que a compressão que tem o nervo mediano no túnel do carpo, igual. Mesma coisa, terceiro nervo, nervo periférico. Depois disso você tem que liberar o quarto nervo, que é difícil de liberar, é um nervo muito mais difícil de identificar, mas é possível. A gente já tem 57 cirurgias desta feita, é uma experiência, estamos falando de lesões muito complexas. E depois disso, a liberação do trigêmeo. Não é necessário tirar o quadrilátero de Kawase. Eu mostrei na foto de Elder, que não é necessário, não precisa. Às vezes precisa, né? Até às vezes precisa, mas não sempre. Por que eu falo isso? Porque todo mundo que fala que vai para a fossa média, fossa posterior, fala que tem que tirar o quadrilátero de Kawase sempre. Não. A neurocirurgia não existe sempre, nunca, tudo, nada. Esse tipo de coisa em medicina não é uma coisa que seja muito legal. Aqui você tem a liberação do trigêmeo, do quarto, terceiro. Além disso, eu abri o cabo de Meckel e vocês podem ver que a ressecção tumoral não é completa. É uma liberação dos nervos da parede lateral do seio cavernoso. E deixa a porção intracavernosa, porque se você tira essa porção, o doente fica com déficit neurológico. Então aí vocês têm a ressonância magnética e o mais importante é que o doente recuperou o terceiro nervo e voltou a ser piloto de avião. Os pilotos de aviões têm um controle oftalmológico que é muito mais severo que qualquer pessoa normal, porque dirigiram um avião. Assim que foi um sucesso da cirurgia. Então, esta é uma filosofia que parte do conceito brasileiro, que é de Verbal Gabriel Figueiredo, 2007, militerional. E a gente começou fazendo a lima paractinoide, que é aquilo mais simples, que eu vou falar, acredito que amanhã, de paractinoide. E depois a gente foi fazendo cada vez mais complexo e fez esta cirurgia. A gente publicou em agosto de 2023 no Atendendo Neurosurgery 2 vídeos desta cirurgia. Aí está o after, e se você tira uma foto do código QR, você pode ver o vídeo no seu laptop ou computador, onde você quiser. Aí, nesse vídeo está tudo explicado, a anatomia, explicada a cirurgia, explicada com 2 casos, a parte do seio cavernoso, fossa posterior, tudo. Tá? É muito importante porque o tempo não dá para eu falar muito para vocês. Então a gente tem 3 níveis de cirurgia. E a coisa que eu sempre falo é que nenhuma coisa é nova. Estas são ideias muito antigas, ideias principalmente japonesas. Né? A maioria das ideias que eu usei é de um neurocirurgião japonês que morreu no ano 2000, que é o Dr. Akira Sakuba. Ele foi o que inventou a fronto-órbita cigomática, para que vocês saibam que é uma pessoa importante na base do crânio. Tá? Ele publicou tudo em 1982, tudo. Mas ele fazia uma anatomia muito grande, órbito cigomático e tudo que não precisa. Tá? Então, animal-aracnoide, primeira etapa. A gente tem uma experiência grande de 458, porque operei um caso segunda, 458 agora. E então, minha plata, o que é minha plata? É mínima, fala, tem cabelo vai cirurgiano, eu não faço nada disso. É diferente, é cirurgia extradural. E vocês veem que anatomicamente é possível. Dr. Cabral parece que é um sobrenome. E a visão que você tem é isso aí, você consegue chegar até a fossa posterior, tá bom? Aí tem a anatomia, o doente é igual, fica igual à cirurgia. Esta é uma cirurgia que eu fiz 28 de outubro, e quero mostrar só para vocês. Você tem aí o carótida, cerebral anterior, cerebral média, nervo óptico, basilar, terceiro, quarto, quinto, cerebral superior. É igual que a anatomia, um doente de um crânio-faringioma, que a gente operou. E se você, além disso, usa endoscopia, você consegue chegar até o foramen magno pela traçamento. É muito interessante esta cirurgia, mas você precisa de instrumentação especial que a gente tem desenvolvido. Aqui eu tenho uma foto com o professor Natal, que foi o primeiro em 2005, e o professor Verbal, que escreveu em 2007, a técnica que a gente usa como baseia a cirurgia que a gente faz. O conceito que a gente propõe é que exposure, que é uma esterotomia pequena e uma cirurgia complexa no fundo, para chegar à fossa posterior. Né? Que a gente usa o corredor extradural. Tá? A gente desenvolveu buivas especiais, instrumentos especiais, mas nenhum conceito meu. O conceito de descompressão dos nervos da parede lateral do seio cavernoso é do Dr. William Caldwell, de Utah. Ele foi descobrido em 2006. E a gente tem tudo isso aqui publicado. E vocês podem ver que uma lesão terrível como essa, terrível, calcificação da tenda, fossa posterior, fossa média, fossa pituitária, crinoidal. Você, uma cirurgia, não vou mostrar porque já tomei todo o meu tempo, mas eu vou mostrar pós-operatório. Você tem uma recepção muito boa, fica um remanente na fossa posterior que você faz retrocirurgia, simples. Não precisa fazer transpítulos de Almefte. Eu fiz 100 anatomia da Almefte, não faço mais. Há 8 anos, não faço preciosimoia. Eu sei fazer, mas não faço mais. O resultado é muito melhor, fossa média, fossa posterior. E aqui vou mostrar no final, lóbulo temporal do doente, cerebelo, facial, sexto nervo, pares, nono, décimo primeiro. A ressonância magnética de controle é muito boa e o mais importante, o doente. Ela é a doente que eu mostrei daqui. Uma doente como aparecia, fazer mínima, nada mais. Então, esse resultado conseguir com outro tipo de cirurgia é muito difícil. É muito difícil. E também dá para fazer, não tem tempo só para mostrar que em fossa posterior a gente faz patologia vascular, como esse aneurisma da cerebral superior, e um resultado clínico bom, com cura da patologia do doente. Então, minha plata é uma filosofia boa, uma filosofia possível de fazer, reproduzível. A gente mais nova gosta muito porque é uma cirurgia mais rápida também. E você pode combinar endoscopia e microcirurgia junto. Aqui a gente está operando pela nariz e pela fossa média um adenoma de hipófise. E quando você opera, a gente está desenvolvendo um braço robótico para o endoscópio, com mitaca. que permite fazer aquela visão que eu mostrei para vocês na endoscopia. Para mim, o futuro da cirurgia do vaso crânio é uma cirurgia microcirúrgica e endoscópica, não brigando, fazendo junto. É possível fazer junto e com aquilo conseguir resultado impressionante em patologia que antes a gente não conseguia curar. A gente tem essa missão na cirurgia. Eu agradeço aos meus fellows, eu tenho 55 agora, e agradeço a sua atenção. Muito obrigado.
Obrigado, Dr. Moura. Temos ainda 7 minutos, vamos abrir para a discussão. Se alguém tiver alguma pergunta que queira fazer aos apresentadores, nós não vamos seguir a sequência, vamos deixar à vontade para qualquer pergunta que possa fazer. Dr. Igor, está por aí, não? Ok, alguém quer fazer alguma pergunta? Ok, como não temos perguntas e também pelo adiantado da hora, eu quero agradecer, né, a todos os palestrantes, bem como aos presentes, e está encerrada a reunião. Muito obrigado.
Rodriguez, thank you very much.
Thank you. Thank you very much. Good afternoon, everybody. Thank you for the invitation to be here as a guest speaker. As I was telling before to Dr. Acevedo, I came here as a young resident and I was very impressed by the level of Brazilian neurosurgery. So it truly is an honor to be here as a guest. So thank you very much. The idea of the talk is to tell you about the very, very new novelties that we have in the management of intracranial hematomas and tell you a little bit about a study that we've put together for this pathology that so far didn't have many therapeutic options. So as you know, intracranial hematomas are less frequent than ischemic stroke, but it carries a higher rate of morbidity and mortality. And since it affects a younger patient, it also carries a higher loss of productivity years. Plus, with best medical treatment, which is quite inspecific, actually, we have a mortality of up to 50% during the first year, and only 20% of survivors make a good recovery and go back to a functional life. So we have is a pathology where we have a wide range of improvement, a lot of room for improvement with any innovative in this field. So when we have a hematoma, the brain suffers two types of injury. We have first purely or mostly purely mechanical injury due to the destruction that the hematoma causes in the brain. This causes mass effect and also is going to cause an increase in the intracranial pressure and a decrease in the cerebral blood flow, which is going to produce further parenchymal compression, herniation, and inflammation. This, together with the toxicity from the blood degradation products, is going to start a series of events that are going to cause inflammation and oxidative stress that in the end are going to lead to an alteration of the blood-brain barrier, which is going to cause further damage, which is what we call the secondary brain injury. So considering all these mechanisms, it's easy to understand that both the volume of the hematoma and the volume of this later edema that develops during the first week are going to be independent predictors of how a patient is going to be. And thinking about that and thinking also that 25% of the hematomas increase their size during the first few hours, one may think that surgery may provide a benefit for these patients, right? So this likely role of surgery has been studied during the last 20 years through several randomized clinical trials. The first large of these trials was the Stitch that you might be familiar with, that compared craniotomy, classical craniotomy with medical treatment, and it failed to demonstrate any benefit from the surgery. Most likely because this open surgery was causing iatrogenia that would counteract the possible benefits of evacuating the hematoma. But that helped start developing thinking about minimal invasive techniques that may overcome this iatrogenia from open approaches. And it's not until we start seeing these minimal invasive techniques that we began to see a benefit in terms of survival for the surgery. And these initial minimal invasive techniques also help us to learn a few interesting things. And first of all, that time is brain, similar to what we have in ischemic stroke. The earlier you evacuate the hematoma, the better the patient is going to do. And also that it's very important that you do a significant evacuation of the hematoma. The less hematoma you left behind, the better the functional prognosis of those patients. So all this knowledge also helped developing these techniques, and we went from the earlier type of techniques that were the ones that were used in the MISTI trial. So we were using a stereotactic catheter and administering fibrinolysis through this catheter, and then the hematoma would evacuate in a passive way, so through several days, right? So we would achieve low evacuation rates. And then we went to more complex techniques that require intraoperative imaging and neuronavigation, endoscopic evacuation, but were a one-time procedure that allows a higher evacuation rates and even coagulation of bleeding vessels. So with the very good results of the first cohorts with these techniques, these new techniques that were called the scuba techniques for the similarities with the scuba diving, we'll see it later. So with these very hopeful initial results, in the last two and a half years, several clinical trials have started studying these techniques. There's a trial from the Netherlands, a trial from United States, the INVEST. So just a few months ago in the AANS meeting, the American trial, the ENRICH, already said that for the first time we are seeing benefits in terms of functional outcome with surgery, with surgical evacuation of hematomas. But even before the publication of these results of the ENRICH trial, already the American Heart Association guidelines were saying that minimal invasive surgery was the treatment of choice for hematoma because it reduces mortality and most likely improves functional prognosis, whereas classical craniotomy has no clear prognosis or mortality benefits, and it should be only a life-saving technique. So with this, all this knowledge in mind, it seems that we need to start including this technique in our armamentarium, right? But it's not so easy, at least not in the Spanish health system, where they won't pay for all the things you need to do it unless we have already clinical trials that prove their benefit. So we think of putting together a research study that allow us to get the funding to do this technique. We did a multi-center study, and we got the attention of the reviewers because we obviously don't have the means or the infrastructure to do another clinical trial. But we sell them the idea of studying this secondary brain injury that I was telling about, because this type of surgery allows something that is very interesting, and is it is ethically, because you're gonna go through healthy tissue and then you're gonna get to diseased tissue in the same patient. So you can get samples of healthy tissue and diseased tissue within the same patient. And if you compare that to a type of MRI that can measure blood-brain barrier alteration and to brain autoregulation measurements, you can get very good information on what is happening with those cascades that we really don't know. And maybe this is going to allow us to find drugs that would even improve further the benefits of the surgery. So this is the inclusion criteria we put together for our study. These are very strict inclusion criteria. So some of the randomized trials that I mentioned before are doing 10 centimeters to include the patients. We are doing 25. We also require stability CT to avoid that we have bleeding during the surgery. And we are excluding thalamic hematomas because are the ones that usually have worse prognosis, because obviously this new techniques has a learning curve, so we want to get good results in the beginning, right? And we want to get everybody getting comfortable with the technique. So how do you do this technique? So basically, you first need to plan the entry point and the trajectory you're gonna do. This is similar, I don't know if you're familiar with the MISTI trial, but it's exactly the same. So you need to go through the middle of the hematoma, you need to get at least 2/3 of depth of the hematoma, and obviously avoid great vessels, avoid eloquent areas. So basically for basal ganglia hematomas, supraciliar, frontal, somehow supraciliar trajectory is going to be the best one, and for lobar hematomas, obviously it's going to depend on where the hematoma is. So once you have decided on your trajectory, we go to the OR. We position the patient. Very important to position the patient in a way that gravity helps you avoid that blood is getting into your endoscope, because otherwise you're not going to see anything. And that was one of the mistakes we did with one of our first cases. Once you have your patient position, you're gonna do a small incision like the one you would do for a subdural hematoma, bar hole, and then you, because of our study, we would take the tissue samples of the healthy tissue, and then we introduce a navigated 19 French introducer, the ones you see here. It was the video that was showing here, and then through that introductor we get the endoscope, and the key thing here is this device, which is a suction that has a rotor in the tip that you can see is protected, but at the same time that is sucking the hematoma is destroying it, because if you try with a regular suction, it's not gonna work. So this is a recreation, very fantastic. Doesn't look like this in real life. Actually here, the patient is not even clamped. But so that you get an idea of how the process is, we get the introduction with the navigation. Once we have the introduction in place, we can get the endoscope with the suction device, as I said, the Artemis device. This is the limiting factor, I mean the expensive thing, because these devices are only one-use device and are quite expensive, so that's what we needed the funding for. And then you evacuate the hematoma, which here in the video looks really nice. It's not like that in real life. We'll see it in a minute. So once you think you've evacuated the hematoma, you place the tissular pressure catheter. That's because of our study. You don't need to do that, actually. And then we confirm with intraoperative imaging. We happen to have intraoperative CT, but if not, ultrasound is very useful because you can do it in a dynamic way. So you think you have it, you put the ultrasound and check as many times as you want. And once you think you got enough evacuation, less than 15 cc's of residual, you can transfer the patient to the ICU. So here is one of the first cases that we did. Can you play video 1, please? Yeah. So this is a 59-year-old gentleman with this hematoma. He came in hemiplegic and aphasic. So this is how we have the OR. So you see the navigation here, the tower for the endoscope. Our OR nurse, this is one of our residents who's holding the introductor while I do the evacuation. So she's making sure, she's checking the navigation, making sure the introductor doesn't go anywhere while I do the evacuation. Can you play this video, please? So this is more of a real evacuation. So you see, it's not so easy, not so beautiful as the recreation we saw before. But basically, you need to do quadrants. You go from distal to proximal, and once you think you have a good evacuation, you fill the cavity with saline to check for bleeding points. Sometimes, can you play this video, please? Sometimes you get lucky, you get a clot that you can establish clot that you can get out nicely. So it's very satisfying. And can you play this video, please? And this is the CT that we got. It's not very nice. I wasn't very happy about this CT. It doesn't look perfect. But actually, the patient did really, really well. His practically asymptomatic, a little bit of a slur speech, but just because I know that he had the hematoma. Otherwise, you wouldn't completely recover from his motor function and the speech. So basically, we finally have a technique that seems that is improving not only mortality, but most likely functional prognosis in intracranial hematomas. Obviously, the evidence for this technique is developing, and obviously this has a learning curve, so still we need to hold our horses, but very, very exciting panorama ahead. That's it. Thank you.
Thank you very much, Dr. Hernandez, for this very provocative paper. It might be a game-changing information. If you have time, you can discuss later on. Now it's my pleasure to invite Dr. Eduardo Vieira, who did his residency at the Hospital da Restauração in Recife. Now is a faculty member of this of our hospital and the head of the unit of cerebrovascular disease. Also, he's a member of the cerebrovascular committee of the WFNS. He's going to talk to us about microsurgery of paraclinoid aneurysms in the era of endovascular and flow diverters. Thank you.
Sim, sim. Passa o computador. Bom, boa tarde. Queria agradecer a presença de todos para essa sessão de vascular. A gente vai falar sobre o tratamento microcirúrgico dos aneurismas paraclinoideus na era dos direções de fluxo, dos direcionadores de fluxo. Oi?
Quer falar em inglês?
Posso?
Okay.
So, we're going to talk about microsurgical treatment of paraclinoid aneurysm in the area of flow diversion, when and how. This is our current experience, almost 10 years. We're not going to go through it in details because of the time, but in our experience, paraclinoid aneurysms were the third most common aneurysms. And that's because those aneurysms frequently present with large size and wide neck, which is something that makes endovascular treatment more difficult, that's for sure. And that's what we can see here. In our 90 patients, almost half of the patients had aneurysms larger than 10 millimeters. More than 90% of the patients had aneurysms with wide neck. And also, almost 2/3 have presented with subarachnoid hemorrhage. So that's why we operate so much this kind of aneurysms in our department, because of large size, wide neck, and high percentage of rupture cases. From 2011 on, and when flow diverters were approved by the FDA, no doubt it was a game changer in the treatment of paraclinoid aneurysms. But there are still some cases when surgery is needed. Of course, these are not absolute contraindications for the endovascular treatment, but for ruptured aneurysms, dual antiplatelet therapy can be dangerous during the acute phase after subarachnoid hemorrhage. Also aspirin allergy, because you can't do the antiplatelet therapy after applying such a device. Young patients, it is proved that young patients with flow diverters, they are more, it happens more in stent stenosis after embolization with flow diverters in young patients. And of course, very large and giant aneurysms, because flow diverters usually don't deal with the mass effect and also don't treat the abluminal disease, which is a very important thing in such large aneurysms. Well, what are these paraclinoid aneurysms? Are those that originate between the proximal dural ring and the origin of posterior communicating artery. Of course, it is extremely important to know the anatomy of the anterior clinoid process and also how to perform the anterior clinoidectomy, and not only the anterior clinoidectomy, but also the dissection of the dural rings, especially the distal dural ring. It is very important, especially in those medially projecting aneurysms. So what we want to do, we want to take the clinoid out and have something like this, not only the clinoid, but also the optic strut, and you can see the clinoidal segment of the internal carotid artery and both dural rings, and then you can dissect the distal dural ring and try to occlude the aneurysms. That's how we usually do it. Of course, we start with opening the dura. We always do it intradurally, and first we unroof the optic canal, and then we remove the anterior clinoid process, and then the optic strut. And then after, obviously, you're going to dissect the distal dural ring. Usually we use a pterygium craniotomy, a regular pterygium craniotomy, but for small aneurysms we can use the lateral supraorbital, and for the larger ones we can use the orbital pterygium craniotomy. Cervical ICA control is important to do for ruptured case. We always do it, but for unruptured aneurysms, only in selected cases, those large ones, those small, mid-sized ones, we usually don't do it. We try to have the proximal control in the clinoidal segment of the internal carotid artery. We always do the clinoidectomy intradurally, intraoperative microdoppler. We don't have ICG, so we always use intraoperative microdoppler. And intraoperative monitoring of evoked potentials we use when available. It's not always available. Of course, paraclinoid aneurysms aren't just one kind of aneurysm. There are several variants. We're going to go through some cases and show you some of these variants. First, the superior paraclinoid aneurysms, which are the true ophthalmic aneurysms that are related to the ophthalmic artery, such as this case, this large ruptured case. Here we can see the video, and we are on the left side. So here's the carotid bifurcation. So we start doing the clinoidectomy. Here we are starting to dissect the distal dural ring, and here we start to dissect between the aneurysm and the optic nerve, which is here. And here you can see proximal and distal neck. Now we are preparing to apply the first clip, which is a fenestrated clip. This kind of clip have more closing pressure on the tips of the clip, so that's why you use it. We are not leaving anything in the fenestration. It's just because they close with more power. And there's this small neck remnant here, which we are closing it with this third clip. And now you can open the aneurysm and relieve the mass effect. This is post-operative angiogram, and this is the patient. And this is the patient in the clinic. She did very well. The second most common are those medial aneurysms. Also called superior hypophyseal aneurysms. They protrude to the chiasmatic cistern below the optic nerve and the chiasm. This is a relatively common case of this kind of aneurysms. Patients with progressive visual impairment, and then it starts with the ophthalmology, and then they demand an MRI scan, and then you can see the aneurysm. So here we start, you can see how large the aneurysm is. Here's the optic nerve. And then we start performing the clinodectomy. For these cases, you have to do it the complete anterior clinodectomy. With the optic strut here, we are removing it. And now we are opening the falciform ligament. Here's the optic nerve. And now you can dissect the dural ring. Here's the ophthalmic artery. We're gonna go very medially. Here we can see that we are dissecting medially to the clinoidal segment of the carotid artery, proximal to the aneurysm. It is very important to fully dissect this space because that's where the tips of the clips are applied. If you have remaining bone, remaining dura, the clip won't close properly and the aneurysm will keep filling. And here's the 2 more clips to reconstruct the carotid artery. Also for these aneurysms, it's very important to check all the time PCOM and anterior choroidal artery. They have to be free, and now we are checking the patency of both arteries. And then you can open the aneurysm and release all the mass effect of on the optic nerve. Here's postoperative angiogram and the patient on the clinics. Ventral aneurysms are those they are like PCOM aneurysms, but proximal to PCOM. They are not very frequent. This was a patient that did a CT scan because of headache and find this paraclinoid mass, which was this aneurysm. You can see that it was a ventral one. As we can see here, the carotid is pushed up and laterally. Here we perform the clinoidectomy, and this is we are applying here a temporary clip on the clinoidal segment, and we started to reconstruct the carotid. Of course, this is a pilot clip. We're just using to provide some scaffold for the second clip, and now we're going to remove it, and then the carotid is fine now, and we can remove the temporary clip, and now we can puncture the aneurysm and deflate it. And a second clip is always good in these cases of large aneurysms. Never trust only one clip. This patient had also a small superior ophthalmic aneurysm, which we clipped here. And this 4th clip is dealing with this residual neck here. It's microdoppler. And now we can open the aneurysm and deflate it. This is postoperative angiogram showing complete occlusion of the aneurysm and preservation of the carotid artery. This is the patient. Clinoidal segment aneurysms are a very challenging one because they lie between the proximal and distal dural rings, and they are covered by the anterior clinoid process, like this one. You can see that the distal neck is proximal to the ophthalmic artery. This patient was allergic to aspirin, and this is the clinoid process. And you can see that you have the clinoid process, the aneurysm, and then medial is the carotid artery. So that's what we see here. Here's the aneurysm. And now we are finished the clinoidectomy, and now we are dissecting the distal dural ring, which lies right in the dome of the aneurysm. Here's the distal neck, optic nerve here. Of course, in this case, you have to perform a cervicotomy for proximal control. And of course, it's more bleeding because of the opening of the clinoidal space and some bleeding from the cavernous sinus. Here we can see the ophthalmic and the carotid artery. Here's the proximal neck, which we are closing now. And another small clip here to close this remnant. Now we can open the aneurysm. And just for safety, this fourth clip. And here's post-operative angiogram showing complete occlusion of this. One last case of a medial projecting, but more proximal to the superior hypophyseal artery, which are the carotid cave aneurysms. This patient, she presented with sudden onset headache, but upon CT scan, she didn't have any hemorrhage, but she performed a lumbar puncture and there was blood in the CSF. Here we can see after clinodectomy, we are looking for the aneurysm. Here's the distal dural ring and there's no aneurysm here because the aneurysm was proximal to the distal ring. And here we can see the ophthalmic artery. And the aneurysm is right here. This is the proximal neck. And we are now clipping the aneurysm with this right angle, the 90-degree angle fenestrated clip. And it's the intraoperative Doppler. So here we can see the clip closing the aneurysm, the carotid. Of course, there's small stenosis here, but it is hemodynamically, clinically irrelevant. This is a post-operative angiogram and the patient. Of course, there are those giant ones that are not amenable to clipping. I'm going to go fast here. This, that can't be clipped, and the only way is to trap it and perform a bypass. Tomorrow I'll talk more about bypass, and sometimes it is necessary for this kind of aneurysms. I'm going to skip this part of clinical outcomes because of the time, but I want to, this is the main difficulty with these aneurysms, which are the visual outcomes. We had 5 cases in which was worsened vision, and the only thing that were common to all these aneurysms was that they were all medial, superior hypophyseal, or superior medial to the optic nerve and carotid cave. And I believe that the main reason of visual worsening in these cases are not is manipulation of the optic nerve during dissection and its perforators. So we need to take extra care for these medial projecting aneurysms regarding visual outcomes. So concluding, despite the advent of flow diverter stents, there is still room for microsurgical treatment in selected cases. And microsurgical treatment in high volume centers is safe and effective with high occlusion rates and low neurological morbidity. Thank you.
Thank you. Very nice. Congratulations. Now, it's my pleasure to ask to the podium Professor Tao Wang from China. He's going to talk on carotid arterectomy versus CAS, rational choice of case with carotid disease. Professor Tao Wang is professor and chief of the Department of Neurosurgery at the Peking University Third Hospital. He is one of the biggest expertise on carotid arterectomies in China and in the world. Professor Tao, welcome to Brazil. Thank you very much.
Thank you for you introduce myself. My topic is carotid endarterectomy versus carotid artery stenting. Regional choice of cases with carotid disease. I'm from China. It is well known that China has one of the highest incidence of stroke in the world. And carotid plaque rupture and floating into the brain blood vessel is one of the main causes of cerebral infarction. And CEA has a history of 70 years. And there are two therapy methods for severe carotid stenosis, CEA and CES. Which one? And a study from endovascular talks about the investigation reviews disease. And they reviewed more than 100 patients, and about 91% underwent CEA, and 9% underwent CES. In recent years, there are many interventional clinical trials on the comparison of CEA and CES. In general, CEA has a slight advantage over CES, but in some trials, the advantages of both are considerable equal. For example, the famous trial CREST. CEA has and CES has the similar net outcomes, though the individual's risk vary. Lower stroke with CEA and lower MI with CES. So where does the balance of CEA and CES land? I'm already performed CEA about 5,000 cases and carotid body tumors more than 2,000 cases. And help dozens of hospitals to perform CEA every year to popularize the CEA all over the country. And several hundreds of advanced neurosurgeons from all over the country being trained by me to further study CEA in recent, and including doctors from overseas. And our future is that a small incision and operation times less than 1 hour, and no drains, no kisser. There are two surgical methods, standard CEA and eversion CEA, and the bypass rate is less than 1%, but some surgeons used to start for every person. Actually, I prefer to use carotid patch, and only CEA can be performed tracking sutures to repair initial damage, and we use NIRS or TCD. Well, preoperative left carotid artery stenosis with calcification, post-operative vascular opacity. The difference of CTA before and after CEA was very obvious. Post-operative vascular opacity. And the CEA and CS completely and reinforced each other in many cases. How to treat instant stenosis after CS? Invitation, follow dilatation, stent again, or CA again. For example, the instant restenosis, 2 stents, we remove the stent and plaque during the operation, and remove the stent and plaque. We can see the plaque grow into stent, and the post-operative ultrasonography, post-operative widen artery. Case 4, we can see carotid embolic protection system umbrella was stuck in the stent when interventional therapy in our hospital. The patient was rushed to our hospital. We can see the carotid umbrella and the stent. remove the carotid embolic protection system and stent, carotid embolic protection system and stent, post-operative. This case is a 81-year-old patient developed TIA again 3 months after underwent stenting. We removed the stent and the plaque after operation. Case 6 is restenosis again after stenting. The plaque grew into the stent tube post-operation. Another case is the similar. So it's this hard stalk-like plaque that's causing the restenosis of stent post-operation. This patient is developed transient blindness. So we suggest choosing CA rather than CS for this hard calcified plaque. And more suitable for CS in the following case: carotid dissection. Carotid bifurcation is too high to explore, and the intracranial stent, and the restenosis after CA, and the cellular renuism. And in this case, the patient was underwent interventional therapy in another hospital when the right SA is found occlusion. But the revascularization failed. The neurosurgeon at the hospital referred the patient to me. The right SA blood flow was reconstructed successful. However, 3 months later, follow-up examination revealed the cellular aneurysm at the right side of the region vascular inset. So the post-operative blood vessel was the patient again. We sometimes severe carotinosis with coronary stenosis with calcification suitable for CA. Stenosis of 3 coronary arteries. So simultaneous carotid CA with CABG. A heart surgeon and neurosurgeon were operating together, remove the plaque after operation. The stenosis with severe calcification. The calcified plaque is very, very hard, stone-like, and difficult to cut. Just imagine this situation. Place the stent can open the vessel. So we don't suggest using CAS in following case, especially stenosis with severe calcification. And this case is tranced and angled. The plaque is transection at the intraplaque hemorrhage was found. And sometimes we don't suggest using CAS in the following. The narrow insert segmentation is ICA if ICA was very smoothly. So in this case, we choose better CA than CS. It's a long segment after operation. It's a hybrid CCA occlusion. And in this case, we can use carotid subclavian with carotid. We use artificial vessel to bridge. It's a cross middle line. When we deal with carotid artery disease, CA and CS are not tit-for-tat animals, and they are comrades in arms against animal carotid diseases. So in fact, the indication of CA and CS largely overlap with each other. Neurosurgeons should make a rational choice based on patient's special conditions. Thank you.
Thank you very much, Professor Tao. Now I'd like to invite to the podium Dr. Raghuram Sampath. Am I right? More or less. Well, Dr. Sampath is going to talk about stereotactic mini craniotomy and clipping of M2 bifurcation aneurysm. Dr. Sampath is attending neurosurgeon and skull-based and cerebrovascular surgeon at the Department of Neurosurgery at Northwest University, Oregon, USA. Thank you for being with us, Dr. Sampath.
Thank you very much, Professor, and thank you for inviting me to the meeting here. And as I've been hearing other speakers here, I'm just so honored to see how much great work other surgeons are doing in this part of the world. My first visit here. So again, thank you for letting me be part of the panel presenting here. So I picked this particular case to discuss, and as I go forward, so this is a procedure I had done, and I'm using it as an example of why we should still train our residents in microsurgery, and even in the era of endovascular treatment, there is a role for teaching good skills to our residents. Or does this proceed forward? Can you go forward? So this is a case I'm presenting. This was a 59-year-old lady who presented to the emergency room with dizziness and some syncope and just feeling overall weak, history of hypertension, family history of aneurysms, and just not appearing right, appearing as though she's not behaving herself, and that's what the family brought her in. So that's the presentation. Could you start the video, please? Could you play the video, please? The video is here. Okay. I think you have to play the video from there. It's a video.
Por favor, para começar a passar o vídeo no slide aí.
Dizziness, syncope. Her exam was normal, no neurological findings, except that yes, she was tired and not answering questions well. So as part of considering stroke workup, she underwent a CT angiogram, first revealing a right MCA aneurysm at the bifurcation, but also a left distal MCA aneurysm at the M2, M3 bifurcation. So the angiogram showing the right MCA aneurysm, which was much larger, larger in size, more complex, irregular surface. So this was treated first. We discussed endovascular and open surgery options. It was felt better to treat it with open surgery. This is a postoperative angiogram showing occlusion of the aneurysm. So the right side aneurysm is treated. This is the postoperative 3D angiogram showing the area that was clipped at the MCA bifurcation. So this was the right side. So we treated that first. So once that was done, this is the angiogram showing the left side M2-3 aneurysm, the lateral projection showing where this is located. So it's basically a bifurcation aneurysm. And now considering and focusing on treatment of this side of the aneurysm, again, options of endovascular management with web device or coiling or stent coiling, all were discussed. I always try to get a T2 thin cut MRI for all vascular cases. I've seen it being very useful as an angiogram to study vascular and even skull-based nerves and everything. So I use this, and I use this for navigation purposes. And myself and my endovascular colleagues, we discussed surgery as being a better choice compared to web device or other endovascular interventions. And then if you look at this coronal image, it shows you it's just underneath the superior temporal gyrus. So there's an approach available through the sylvian fissure. So this is distally located in the sylvian fissure. So again, the rationale for A, it should be treated because she has multiple aneurysms, family history of aneurysm, presented with headaches, one side aneurysm, large, already treated. So that's the rationale for treating it. And young patient, better chance of treating this with complete occlusion with surgery as compared to web devices or coiling, which have a higher recurrence rate over a 2 to 5 year period. So that's why we chose surgery and not the alternative endovascular approaches. So consent was obtained, risks explained as standard for any procedure. For vascular cases, risk of stroke or hemorrhage, and because it's the left side, speech deficits. So she was positioned supine with a shoulder bump, head was turned towards the right side. You see us utilizing the navigation microscope with ICG capability and standard micro instruments. So next, looking at after the opening is made, so because we use navigation, we could focus right on top of the aneurysm and make a small opening and the navigation pointing to exact location of where the aneurysm is located. So a very small 3 centimeter mini craniotomy made in the left temporal area. And now again, after the dura is open, locating the with navigation. So that's the sylvian fissure, the distant sylvian fissure, temporal lobe on the left side of the screen and frontal lobe on the right side of the screen. And this is the area which I decided would be the best spot to open the sylvian fissure, and the location of the aneurysm right underneath the superior temporal gyrus. So sylvian fissure distally being opened with a diamond arachnoid knife, and then opening rest of it with micro scissors. And as we kept going deeper and deeper, careful dissection to preserve all the vasculature, and doing time to time blunt dissection, time to time sharp dissection. And in this way, we open the fissure, again, making sure enough is opened and not excessively to land right on top of the aneurysm. So as more and more fissure is required to be dissected, it's opened, and here we are on the aneurysm. Again, first I'm trying to find the proximal flow, the M2 within this. So surrounding small gliotic plane is being coagulated and cut. And as the dissection is carried forward, then getting close to the neck and the M2, first I want to then find the 2 exiting branches, the bifurcation and the M3 vessels themselves. So after this is done, this is a superior division of that M2 bifurcation, which we saw on the MRI, so that's identified. So we have one of the distal controls, but we still don't have proximal control. So again, opening the fissure is kept to as much as only what is needed and not opening it excessively. Of course, that does put a little bit of pressure on the superior temporal gyrus. So as we get further and further in the dissection, again, cutting small. So now we see the M2, the inlet, the feeding artery, the proximal control is coming into view. Once this is identified, put a temporary clip on this one. And my first time that I try to clip an aneurysm is if I don't have enough space around the aneurysm, I just put a testing clip. It's still a permanent clip, but it allows me to look around the aneurysm as it's decompressed now. And then I noticed that there's a residual neck, and though I have to reapply the clip in a different configuration, in a different manner. But having done that again, I noticed that, again, there's a neck residual left, right where the M2 is entering. So now that it's been a few minutes since temporary clipping, the temporary clip is removed to allow perfusion, and microdoppler is used to confirm flow within the surrounding M3 branches. So once this is done and the flow is confirmed, I continue dissection. One of the clips, the two of the clips are left on the aneurysm. At least the dome is protected because too many clips in this small area will crowd up the space and obscure visualization. So once this is continued, again, now we have a better view of the angio architecture here. The both M3s coming out of it, the residual neck that's still left, that's not clipped properly. So, and dissecting it a little bit more to give us even better visualization. And then once we reach this stage, and I know very well where the M3s are, and where the M2 parent vessel is, then again apply another temporary clip. So the temporary clip goes back. The aneurysm is now soft and deflated. Again, in this location, perforators are rare, so I don't have to watch too much of where the temporary clip is going. So the permanent clip is reapplied, and I look again all around. It looks like I've got the neck this time. The temporary clip is removed, and the first thing after that is to confirm with Doppler flow as to the flow within other vessels. And then the aneurysm is clipped. There's not much signal noted on the dome, but I still feel that I should put another clip around the initial clip. Now is when I'm listening for any signal within the, so this is papaverine being applied to allow for vasodilation. A second same shaped clip is applied just to give extra boost, and then an intraoperative ICG is done. So the filling of the both the M3s is noted here. That's the superior division. And of course the filling from the M2 itself, and we already saw filling in M3. So closure in a standard manner, and post-operative angiogram is done. So disease background, if I can pause this. So M2, M3 location aneurysms, should we call them distal MC aneurysms? In a way, yes, it's not an M1, MCA bifurcation aneurysm. These are rare. There's not many series reported unless you dig into each published paper and look into the sub-analysis of how many M2 and M3 aneurysms were noted. But roughly there will be about 1 to maybe 4%, maybe the incidence of these. So this is again showing the post-operative angiogram showing clipping of this aneurysm. And there is a 3D as well I'll show. Yeah, that's the aneurysm was located. I don't think sorry, I clicked the wrong button. Can you hit that play button, take the video till the end? I just have one more slide after this. I'm almost done.
Por favor, passa o slide.
And please take the video all the way to the end.
Só se tem como correr o vídeo até o final.
Could you play it, please, and then take it all the way to the end?
Aqui não está aparecendo a barra. The bar is not showing for them to forward the video.
Oh, okay. Okay, well, it's not showing, but I don't think it's playing either. Okay, I'll go to the next slide in interest of time. So it was clipped. She did well, clinically well. The angiogram showed occlusion. Then of coming back to this location of aneurysms again, I saw one paper published from China which gave it a category, subclassification of MC aneurysm. They called it a C, type C, being at the M2, M3 bifurcation. Again, these aneurysms are not dissecting or infectious type of aneurysms that we see with distal MCA, mycotic aneurysms. So I don't consider them completely distal in location in terms of M4 or M3 and M4 vessels. They are at a bifurcation. So this is again a concept that we should know that treating endovascularly is the recurrence rate may be similar to as what we see with bifurcation aneurysms. And using a T2 MRI, really a thin cut with navigation, really lets you study the vessels coming in and out of the aneurysm. And again, being well aware of the anatomical approaches with Sylvian fissure dissection gets you to the neck very well, and complete occlusion in patients such as these type who may or may not follow up well for angiograms down the line, may or may not take dual antiplatelets. So this is a situation where I feel even dislocation aneurysms are better treated with open surgery, and something we should all be teaching our residents. Thank you.
But and now I would like to invite our next speaker, Dr. Kai Michael Schoeffler. He's going to talk about the current current experience in microvascular surgery in Germany. Dr. Schoeffler is the director of the Department of Neurosurgery and teaching faculty at University Hospital of Düsseldorf in Germany.
Thanks, and thanks for the kind invitation to this great venue. Now we're seeing quite some advanced cranial microsurgery for aneurysms, and the question is, how is the reality of the treatment in the different countries? And I think I don't have to elaborate on these stats here in this audience. However, while historically being treated by surgical clip ligation, today's mainstay in many European countries is endovascular therapy, and it has been increased since the late 1990s, step by step. So there were several multinational trials that have sort of hampered a neurosurgeon's job, at least in Europe, and in any case in Germany, which was ESAT, was the first one enrolling more than 2,000 patients. 95% of aneurysms located in the anterior circulation, amenable to both surgical treatment and endovascular treatment. And the mean follow-up was 4 years with primary endpoints, death and permanent neurological deficits. And it showed that the death was occurring 24% after endovascular treatment and 31% after surgical treatment. That meaning a relative risk reduction of over 20% by endovascular therapy. And one of the downsides of that study was, if you look at the data, it was obviously comparing mediocre surgical results paired with high endovascular expertise. So the results are somewhat skewed. However, it left a mark on daily practice. And the second one was the ISUIA, enrolling more than 4,000 patients from Europe, US, and Canada. And it looked at the rupture rate of aneurysms with regard to configuration, size, location in posterior circulation. And it showed that these aneurysms with a larger size located in posterior circulation in a previous history of SAH obviously had a higher rupture rate, whereas they reported an extremely low rupture rate in aneurysms with a size smaller than 1 centimeter. Less than 0.1%, which is obviously not really fitting well in our perceptions of the aneurysms we see on the operating table. So there was a massive backlash from many international neurosurgical societies because these results presented in this large study completely contradicted our real-life experiences. Still, it left a large mark on the neurological community, and as they also provide primary care for aneurysms, at least in Germany, the overall posture towards aneurysm treatment became much more conservative. So this is the single study, a review of surgical cases for aneurysms, both non-ruptured aneurysms and acutely ruptured aneurysms in Germany over a 5-year period between 2005 and 2009. And you can already see here that more than half of the aneurysms in the unruptured population were treated by endovascular treatment, and that was already in 2005. Only 25% of the unruptured aneurysms got treated. 25%, which is a very low rate. So this is the total number of patients enrolled in this time period of 5 years between 2005 and 2009, and the gender predominance was clearly female, 60%. Otherwise, a coherent cohort, and this is the number, or this is the preponderance of treatment if you look at endovascular therapy on the left and surgical therapy on the right. So this is a map of Germany, and you see, looking at the dark blue spots here, this shows a strong preponderance for endovascular treatment as opposed to surgical treatment, and vice versa. Here you see in the south of Germany, there appears to be more colleagues willing to clip aneurysms, whereas here in the very east, with the exception of Berlin, we know who's working there, there's a preponderance for endovascular treatment. There's no scientific rationale. This is just referral bias, basically. So this is the number of patients treated endovascularly and by clip ligation, and this is not the total rate of patients. This is an amalgamate of different metrics, so it's tough to understand. However, the bottom line here is that we got a steady increase of treatment in both groups. So both for clipping, the dark spots here, and for endovascular treatment here. And you see that females have a higher incidence of aneurysms and are treated by endovascular therapy at a greater rate than males. Now that is the representation of the age group, and as expected, you see that the majority of patients with unruptured intracranial aneurysms was treated between 40 and 65 years of age. Same goes for clipping, of course. Okay, we're not moving. Not moving. Not moving. Here we go. So obviously we've got a paradigm shift. We have around 115 neurosurgical departments in Germany treating intracranial aneurysms, and that means that leaves 2,000 interventions for unruptured intracranial aneurysms per year. And there has been an increasing use of endovascular therapy since the late 1990s. The endovascular therapy to surgical treatment ratio was already greater than 1 after 2007. And the reality now is that for anterior aneurysms, the ratio is currently 1.5 to 2 in many hospitals. And for the posterior circulation, endovascular therapy is carried out 10 times more often than surgical therapy. So that leaves us as neurosurgeons with an increasing number of complex cases like giant aneurysms and so on. I will elaborate on that a little later on. However, there has been a gradual increase in neurosurgical departments never or very seldomly executing surgical therapy for ruptured and unruptured intracranial aneurysms. So there are neurosurgeons who have never seen an aneurysm in their whole life. So there's a growing divide between high volume and low volume centers. So the yearly average number of surgical therapies for intracranial aneurysms in active programs is around 50 to 80. So 50 to 80 aneurysm surgeries per year per department, with an increasing number of complex aneurysms predominantly located at the anterior communicating and middle cerebral artery. And the growing problem is that of maintaining surgical expertise, specifically for treating giant aneurysms, posterior circulation aneurysms, and bypass techniques for different pathologies. Another factor that has an impact on surgeon training is the EU law work time restrictions, because surgeons are no longer allowed to remain in the hospital after on-calls. So that means they have to go home and cannot be present in the operating theater the next day, which has effectively cut down training time by 30%. We have other profound impacts, again by European law, on surgical devices. So there is a new law that prohibits surgical instrument and implant manufacturers of selling implants as well as instruments that have not been proven safe and effective by clinical evaluations. So they have to provide extensive studies showing the efficacy of the instrumentation. And most of the surgical manufacturers have said, well, we're going to drop out of the market for the European Union and will exclusively sell for the rest of the world, like South America, India, and so on, no longer in the European Union. So we're seeing a steep decrease in our instrumentation. There's only one neuroendoscopy manufacturer left that can supply neuroendoscopes in the European Union. And the same goes for neurovascular surgery, clips, instruments, bypass instrumentation. Sorry. Doesn't move. Doesn't move. All right. So the realities in the coverage of ruptured and unruptured aneurysms is that we have an increasing centralization of effective fellowship programs. We have a steep trend towards subspecialty training that limits the overall case numbers for microsurgery, basically for all trainees. So there's less exposure to microsurgery for all trainees, and there's a growing number of completely ineffective programs, even at large teaching hospitals. So most patients with standard unruptured intracranial aneurysms will opt for endovascular treatment. So will decide against microsurgery, which is another factor that is critical for us. In my opinion, you need at least 50 surgical therapies for unruptured intracranial aneurysms for an effective fellowship, and also to maintain treatment quality, which requires an orchestrated effort of surgical and endovascular programs. However, in Europe, specifically in countries like Great Britain and also France, we have a very competitive economic environment between radiology and neurosurgery. So it's not just indication driven, but also economically driven. In treatment, we have different primary caregivers. We have currently neurology, neuroradiology, or neurosurgery. So patients are divided up into different primary caregivers. And neuroradiology is part of radiology, not neurosurgery, in basically all of Europe. So that means we are not in control of what's happening to our patients. And obviously that distribution of patients between specialties reduces experience and treatment quality. So integrated neurovascular fellowships combining EVT and surgical therapy are not yet established in all of Europe, which is a great drawback. However, there is an interdependence of surgical therapy and endovascular therapy. For instance, we see that endovascular therapy is clearly favored in low volume environments. That means the less treatments any hospital provides for intracranial aneurysms, the higher they favor endovascular therapy over surgical therapy. And the quality of endovascular therapy will decrease also with the low caseload. So any unexperienced radiologist will produce worse results than an experienced colleague, of course, like in surgery. So the typical complications of low volume endovascular therapy are thromboembolic events, incomplete aneurysm occlusions, intraprocedural ruptures, and periprocedural adverse events. And of course, what we see nowadays is that we have to treat aneurysms that have been previously treated by endovascular means, which is not, this is not a surgery that is appropriate for training. So high volume endovascular therapy and surgical therapy increase quality, of course, and the integration of endovascular therapy and surgical therapy, as we see in other countries of the world, obviously boosts the quality of the overall treatment. And the crossover between surgical and endovascular therapy is feasible. So that shows that it is not just about what we can treat, but also what we are politically allowed to treat. And we're, at least in Europe, are living in a very, very fluctuating and very dynamic environment that does not favor surgical therapy. Thank you.
Thank you, Dr. Schöffler. I'd like to invite our next speaker, Dr. Jorge Moura from Chile. He's going to talk about revascularization in acute stroke beyond decompressive craniectomy. Dr. Moura is former president of the Chilean Neurosurgery Society, and he's a professor at the Universidad de Chile.
Falta o cabo de HDMI. Bueno, muito obrigado pelo convite. Eu já é minha segunda palestra. Para mim é uma grande honra sempre falar aqui no Brasil. E eu vou falar um tema que é um pouquinho controversial. Como falou o colega também eu vou falar um pouquinho em inglês para que ele entenda, tá? Very nice your lecture, doctor, about endovascular and microsurgery, and I'm speaking in English in order to you understand, okay? Because I speak in Spanish or Portuguese, and for me it's very interesting the approach that you put in the lecture. What we are doing in Chile, and I know that in Spain they try to, is the neurosurgeons. I have a fellowship since 2000 in microsurgery, but now my neurosurgeons go to endovascular after finishing the microsurgery. It's the only way. There's no other way. And I think the ischemia is the same. Because I'm going to talk about ischemia now. And ischemia now is pure endovascular. Okay? When you think about ischemia, you think about endovascular. But why? Because when I made the residency, everybody said, no, ischemia is for neurologists. The neurosurgeons, we have nothing to do with ischemia. And that's the problem, because the neurosurgeons leave the things. I started my practice in 1995, and I was in the first coil that was put in Chile, 1996. Pedro Lilic, an Argentinian one, very famous. And I don't like it, but I rather prefer to operate. But what I saw, I saw this thing is easy, it's very reproducible. They're going to take over, you see? But if we think about this 23 years after what happened with endovascular, we're still operating. And then what we need to do is improve, do less invasive surgery, mini approaches, develop new instruments. I work with Peter Lasik. I saw that you have the L clips. Now we have the D clips are better. The appliers are better. I designed the applier. And I think we can improve the microsurgery. I'm not saying that endovascular is not good. No. We need to do both. Okay? And in stroke now, I'm going to talk, but I talk in Portuguese, I'm sorry. My idea is the neurosurgeons need to be involved. That's it. My only message. Okay? We need to respect the endovascular. They did the job. They did the job. They did the publications. They work with the neurologists. They did all the job. But we can take back the job. and do the neurosurgeons with what we know to do. And I show you the patients that I did not operate, was my fellows, because the important thing now in the 21st century is not about what Dr. Mura can do. It's not important. It's what the young neurosurgeons can do, what the young neurosurgeons want to do. That's the message. Because in my hospital, for example, today, I'm here. It's impossible for me to treat a patient. If I don't have a team, there's nothing I can do for the patient, you see. We need to change the message. And agora vou falar em português. Eu agradeço sempre meu estágio que eu fiz com o Dr. Evandro em 98. Lá, na época, aprendi que a neuroanatomia, a microcirurgia é o mais importante. E outra coisa que ele tinha muito interesse em bypass. Mas era bypass que a gente fazia com ele, era um bypass para aneurisma cerebral. Mas eu achei muito interessante o conceito de bypass. E outra coisa é que no Chile não tinha ninguém que fizesse bypass na época. Então, para mim, foi importante o conceito de revascularização cerebral. Tive muita sorte, eu no ano 2009, ainda não sei porquê, me convidaram para o Congresso Mundial. E se vocês veem aí, tem a Lale Gamshekar, Edgar Natal, Jack Morcos e Fadi Charvel. Eu não sei, até hoje não sei porquê me convidaram, mas me convidaram. Então, eu fiquei feliz. E a gente tem que conhecer as boas pessoas na vida para seguir eles. E eu vou mostrar só um caso que eu fiz em 2011. Estamos falando antes de trombectomia endovascular, antes dos estudos que demonstraram que endovascular é melhor, tudo. Essa era uma doente com aneurisma gigante de carótida esquerda, que tem indicação cirúrgica, acredito até hoje, porque a doente tinha um compromisso visual severo, bilateral, era quase cega, então a gente precisava uma descompressão. O aneurisma era subdural, não era um aneurisma intracavernoso. Quando o aneurisma intracavernoso, para mim, a primeira opção é diversão do fluxo. Tá? Mas quando é subdural, com compromisso visual, tem que operar. Então o planejamento cirúrgico que eu fiz foi um bypass de alto fluxo, ou de segunda geração, que era radial, de carótida externa a cerebral média. Mas o que aconteceu? Eu vou tentar mostrar para vocês, porque às vezes meu laptop falha. Não sei, tem um detector de mentira, assim falam aqui no Brasil, não? Quando a coisa não dá, é que tem um detector de mentira. Então eu estava fazendo a cirurgia e não sei por que o anestesiologista desceu a pressão do doente. E aconteceu que o doente desenvolveu um trombo na carótida. Trombosou a aneurisma, trombosou a carótida. Então eu estava fazendo a abertura do baile silviano. Aqui vocês podem ver a cerebral média. Estamos falando ano 2011, 12 anos atrás. Tá? E eu tive uma sensação muito ruim, que quando fui a mexer com a cerebral média estava dura, como borracha. Então aqui eu pensei, nossa, aqui se fodeu, não? Isso em português, não? Como eu pensei, nossa, o que eu vou fazer? Nunca vi nada assim. Então eu pensei, primeira coisa, vai ter que fechar a fonte embolígena. Vou fechar a carótida. E começar a rezar, porque eu sou católico, que a comunicante anterior, leptomeningea, qualquer coisa, tivesse uma perfusão do cérebro, o doente. Porque a cerebral média estava fechada. Uma doente que tinha compromisso visual, mas estava em Glasgow 15, não? Estava bem, falava bem, mexia bem, tudo. Então eu lembrei, num congresso, que o Dr. Spetzler mostrou uma abertura de A2 e ele tirou um trombo. É uma cirurgia que ele fez. Por que eu estou falando isso? Porque é importante esta atividade. Eu fico triste porque normalmente a sala não está cheia. As pessoas não sei por que não querem aprender. Mas sempre, se eu me queixo agora com vocês, é uma coisa injusta porque vocês estão aqui. Tem que se queixar com aqueles que não estão aqui. Então o que eu fiz? Eu abri a artéria, porque eu vi um congresso do Dr. Spetzler, que abriu uma artéria, e vocês podem ver aí um trombo, porque o doente desenvolveu um trombo do aneurisma, que trombosou a carótida da cerebral média. E eu tirei. O tratamento endovascular do stroke agora é a mesma coisa. Se você tem uma oclusão de um vaso maior, o que tem que fazer é tirar o êmbolo. E como tira? Usando um stent retriever ou sucção. Mas o conceito é igual. Então eu tirei aí com muita paciência, pensando que o fluxo fosse bom para sair o coágulo da cerebral média. Então aí, pum, abri a cerebral média. O vídeo não é muito bom porque é 2011, um vídeo antigo. E depois disso eu fiz uma arteriografia, fechei a cerebral média. É importante fazer laboratório, prática com rato, tudo isso. 2011. E depois disso, como eu usei a cerebral média para trombectomia, eu tive que fazer o bypass na carótida. Não tinha jeito de tentar fazer a cerebral média, porque a cerebral média eu tinha fechado, já suturado uma vez, não ia submeter a isquemia pela segunda vez. Então, o que eu fiz? Eu fui à carótida. Então, quando voltei para o pescoço do doente, a radial ficou curta, não dava. Então, o que eu fiz? Eu fiz sutura de tiroideia superior a inserto da radial. E acontece que ninguém tinha publicado isso. Então, a gente publicou em 2011 bypass de fluxo médio, pode ser, de artéria tiroideia superior, radial, carótida. Ninguém tinha feito antes. Por que estou falando isso? Não para falar de que eu sou melhor ou pior que outro cirurgião, não. Que você precisa inovar. Inovação em neurocirurgia ou em medicina é muito importante. Então, 2011, eu achei, nossa, se tem um vaso fechado, é bom, pode tirar. Eu comecei a operar doente. Mas o que aconteceu? Endovascular. 2013 começaram, 2 anos depois. Saiu um trabalho em New England que não era bom, mas depois, em 2015, saiu que era muito bom. Então, eu tive muita sorte na vida. Eu tenho conhecido muito bons cirurgiões. Eu tinha Michael Lawton, professor Kamiyama, Kiko e Rogoya Tanikawa. Muito bons eles, cirurgião. Shubin, que está aí, 12.000 bypass, 12.000 bypass. Eu tenho 4.000 cirurgias em total. Ele tem 12.000 bypass. E com Fábio Charvel também. Então, a gente fez um simpósio, 2019, de isquemia cerebral com tratamento neurocirúrgico. Ninguém tinha feito isso. E juntamos todo mundo aí para tentar começar a pensar se a cirurgia pode fazer alguma coisa. Porque o que faz hoje a cirurgia? Nada. Nada. TPA, tratamento endovascular, circulação colateral é o mais importante que tem o doente. E a outra coisa, que o estudo de stroke hoje é muito bom. A tomografia é muito boa porque o neurologista desenvolveu muito o estudo da tomografia, aspects, tudo uma linguagem que é diferente e que o neurocirurgião tem que aprender. Então, endovascular é bom, é caro. Mas acontece que cirurgiões não sabem cirurgia de isquemia. Então, em 2013 falaram, não é boa. O que fizeram endovascular é que nunca o cirurgião faz, fizeram um monte de publicações. E agora, o standard é endovascular treatment. Porque eles fizeram o trabalho científico. A gente tem que fazer igual. E agora, lógico, o que faz agora a microcirurgia em stroke? Nada. Só faz craniectomia descompressiva, nada mais. Quando já a cerebral média está com infarto completo, não? E a neurocirurgia pode fazer um tratamento de resgate de isquemia? Lógico que pode. Então, hoje o que fazemos? Craniectomia descompressiva, nada mais. Mas a coisa boa é que, ou não sei se boa, a coisa que tem é que isquemia cerebral é muito frequente. É 20 vezes mais frequente que um aneurisma roto. Então, a isquemia é o futuro da neurocirurgia vascular. Não é um aneurisma, MAVI, não. Isso não é o futuro. O futuro é a isquemia. E sempre eu falo, não é uma ideia minha, 1956, sem microscópio, foi a primeira trombectomia. Então, essa pessoa que fez esta publicação é um gênio. 70 anos atrás eu estava pensando, nossa, a gente pode abrir um vaso e salvar o doente. Também pode fazer um bypass se precisa, se não funciona o tratamento endovascular. Sempre a gente tem que dizer tratamento endovascular, tratamento primário de isquemia. Mas quando o tratamento endovascular falha, você sabe quanto que falha o tratamento endovascular? 5 a 10%. Se você trata 200 pacientes por ano, 10% são 20. Quer dizer que vai operar mais ou menos cada 2 ou 3 semanas um doente de isquemia. em um centro normal de tratamento de isquemia. Então, o neurocirurgião tem que ficar envolvido em tratamento da isquemia cerebral. Tá? Esse caso a gente fez em 2013, antes de tratamento endovascular, trombectomia em uma embolia por dissecção da carótida. Eu não vou mostrar porque a gente não tem tempo. Só quero falar que tudo isso não é novo, tem publicações japonesas que são de 2010, tá? Mas tem doente ainda que a gente pode operar. Por exemplo, esse caso daqui tem uma oclusão da carótida esquerda, uma oclusão do 50% da carótida direita, tratamento médico na UTI, e o doente ficava fazendo crise isquêmica transitória. O que a gente fez? Olha aí, tem 50% de estenose da carótida supraquinoidea, um bypass. A gente fez bypass, acabou a sintomatologia do doente só com aspirina, assintomático. Então, cirurgia pode ajudar doente que endovascular não pode. Isquemia, uma semana, oclusão em T da bifurcação da carótida. Hipoperfusão, hemisfério esquerdo, disfasia o doente. O que eu fiz? Uma mini terional, um acesso minimamente invasivo, mini terional, não terional, e depois disso um bypass, temporosilviano, nada mais. Eu não vou mostrar porque a gente não tem tempo. É muito fácil de fazer em isquemia porque você tem que lembrar. Esto me ha pasado. ¿Dónde fue que me pasó? Que no hubo caso, se cortó las 3 veces y no pude volver. ¿Dónde fue? En México. No, estaba hablando en México yo. Estaba hablando, que ella de España se habla en español, pero estaba en México. I was in Mexico 6 months ago, and they gave us a fire alarm. I was talking, and everybody was out, and was a false alarm. And I think it was the vascular guy. He wanted to silence me, and I said to him, "You did this. You put the match in the fire." Bueno, then este doente só com bypass temporosilviano, que é o bypass mais simples de fazer, resolveu o problema. Então, é muito importante que o neurocirurgião, para mim, neurocirurgião vascular, ideal, é lógico, aquele que pode fazer as duas coisas, endovascular e microsurgery. Mas se você vai escolher microcirurgia, você tem que ser capaz de fazer um bypass de primeira geração, ou bypass temporosilviano. Voltamos o quê? Voltamos? Agora se corta outra vez e acabou, não? Lá, podem ver aí. Deixa eu ver. Que raro. Não sei o que passou aqui. Se vê muito raro? Mas não importa. Então, a tomografia de controle também é coisa boa. Melhoria da perfusão, tomografia igual, mas olha só, uma coisa que acontece com a cirurgia. A primeira tomografia é feita pós-operatório imediato, e se você dá uma olhada para o bypass, é muito pequeno, quase não existe. 3 meses depois, é praticamente 2 ou 3 vezes. Então, por quê? Porque a cirurgia tem uma coisa que é maturidade da cirurgia, do bypass. É uma coisa muito importante. Olha a cerebral média na imagem de cá. 3 meses depois da cirurgia é normal. Então, cirurgia pode fazer, pode oferecer ao doente alguma coisa. A gente tentou publicar isso daqui em 2015 e mandamos um trabalho para publicar. Foi rejeitado em todos os jornais que existem no mundo. Que é maluco, que é um idiota, que é uma loucura. Terrível, um comment terrível. Mas a gente fez a experiência, surgical embolectomy, bypass, indicações que são de terça linha, depois de endovascular, e saiu publicado esse trabalho em 2020. Não só nós estávamos fazendo aquilo. E se vocês veem as indicações deles, eram as mesmas indicações que a gente tentou publicar em 2015. Roguya Tanikawa, o neurocirurgião que tem maior experiência em isquemia cerebral, eu peguei dele, só para que você dê uma olhada. O que aconteceu no centro dele? Em 2015, ele parou de operar e começou a endovascular. Então, todo mundo começa a chorar, não? Nossa, o neurocirurgião perdeu. Não, o que ele fez no 2015 é que mandou 3 neurocirurgiões para fazer endovascular. Então, os neurocirurgiões do hospital dele fazem o tratamento do stroke. no es un radiologista ni otro, es neurocirurgião. Então, ele deu uma olhada para o futuro. O resultado é igual, eu não vou mostrar isso daí. Só para acabar, olha só o tratamento. O tratamento pode ser assim, como o centro que tem Rocuya. Tratamento, primeira linha, TPA, trombectomia endovascular. Quando falha, você pode operar o doente. Se o doente tem uma zona que não tem um infarto cerebral e tem isquemia, você tem que operar. Outra coisa é que ninguém saiba operar. Então, o que tem que fazer? Treinar para fazer uma cirurgia integral para o doente com isquemia cerebral. Terça linha, a terapia microcirúrgica é possível. E aqui, esse é um estudo que eu mais gosto de um neurocirurgião que se chama Giri Fiedler, que ele é convidado para todo lugar agora. Ele está fazendo um estudo prospectivo em doentes para fazer uma intervenção microcirúrgica de emergência em stroke, o EMIAS Study. O EMIAS Study demonstra que a cirurgia pode ser feita em doentes que falha a terapia endovascular, com bom resultado. E aqui a gente fez que Shubin é o coordenador, fizemos um webinar sobre isquemia cerebral. Então, isquemia cerebral pode ser operada, não é maluco aquele que quer operar isquemia cerebral, logicamente endovascular primeiro, mas se falha endovascular, a gente pode operar. Muito obrigado.
Our next speaker is Dr. Shubin from China. He's going to talk about revascularization techniques in cerebral vascular diseases. Dr. Shubin is a professor of neurosurgery in Huashan Hospital and honorary vice-chairman of the Wuhan International Neurosurgery Center and vice president of the ACNS.
Why? Which one? This one? Okay, dear colleagues, dear chairman, and my name is Xu Bing from Shanghai Huashan Hospital. Our hospital is a very high volume hospital. We have 4 campuses, and like last year, we have more than 17,000 operation and plus more than 4,000 gamma knife and cyber knife cases. So we are both WFNS and the ACNS training center. Normally we have 800 beds and 40 operating rooms. So this is my personal experience in bypass. By now, totally more than 11,000 cases for bypass. So the indication for ECIC bypass, including the blood flow replacement, normally used in complex aneurysms, and the score-based malignant tumor involving the vascular wall of ICA, such as nasopharyngeal carcinoma. In this case, we should sacrifice the ICA, and before removing the tumor, we should do the revascularization of the cortex at first. The second type is the blood flow augmentation, including the moemia vasculopathy or occlusive ICA or MCA condition. So how much blood flow can we supply for a brain, like a moemia case? For this case, you can see After the both side revascularization, the whole brain was fed by the ECA branches, by the ICA was totally occluded. So actually we can say this kind of revascularization cured the Moyamoya disease. So normally the STA was considered as a low flow bypass, but if you give it enough time, you can see it can be enlarged so much and not only feed the whole hemisphere, but also the contralateral frontal lobe. This is another case, STA, MCA, totally replace the dominant side ICA. So this is a normal donor vessels. We can use saphenous vein or radio artery. Sometimes, mostly we can use superficial temporal artery, STA. For treatment of the skull-based tumor invading the carotid artery is a challenging task. The direct repair, we can use a covered stent. For this kind of patient, there will be a demand for blood flow replacement beyond the hemispheres, sometimes even both hemispheres. So we created a different kind of bypass. So this is our strategy for replacement of the blood flow. Like this patient, the both ICA was totally invaded by the tumor tissue. So we should sacrifice both side ICA, but before we removing the tumor, we should do the revascularization. So this is a balloon occlusion test. We can see the ACOM was quite good. So which means we have a chance to supply the whole brain's blood flow from one side revascularization. So we choose the left side. We use the ECA saphenous vein to M2 segment bypass, plus 2 STA to M4 double bypass. So after the revascularization through the 3 stomas, the blood flow come from the left ECA and totally supplied the both side hemisphere. Then we occluded the ICA, both side. So this is a right side hemisphere, also got some collateral flow from PCOM. So bypass for the nasopharyngeal carcinoma, we cooperated with ENT doctors. Now we have more than 40 cases, all successfully replaced the blood flow for ICA invaded by tumor. After the revascularization, ENT doctors completely removed the tumor soon afterward. By now, the 3 years survival rate can achieve to 100%. Now the second indication is for complex aneurysms. This is the ICA proximal giant aneurysm, extracranial segment. The radiologist tried to put fluid diverter into it, but it's failed. So then he referred the patient to me, and this is a balloon occlusion test. You can see very little collateral flow, blood flow from ACOM and PCOM. So I use this, I designed this progressive occlusive of ICA clips. This is comparing to the Silverstone clip. So this is an intraoperative video. You can see we narrowing the the ICA proximal part around 70%, and in this after 1 week, we totally occluded the ICA. Now you can see the ICA was totally occluded. The both STA, MCA double bypass was all patent, and totally replaced the MCA territory. So this is a type 1, type 2 ICA aneurysm. You can see no collateral flow from ACOM and PCOM. this vessel is very tortured, so it's also impossible to put the fluid diverter into it. So we have to replace the whole hemisphere's blood flow. So the donor artery, we choose the saphenous vein. You can see after the saphenous vein transplantation, the blood flow totally replaced the whole hemisphere's blood feeding. So then we directly occluded the ICA. More distal, the ICA giant ophthalmic artery, it's also pulled collateral from A1 and the PCAM. So this kind of patient, but we can see some still some collateral blood flow. So for this kind of condition, we normally use to replace the MCA territory. So this is a female patient. The STA was too small, so we use the radial artery. This is after the radial artery transplantation, the STA, ECA to M2 segment bypass. Then you can see the whole MCA territory was replaced. This is the intraoperative video. You can see the intraoperative stoma was patent. Even distal part, this is almost the distal part of the ICA with good ACAM and PCAM. The balloon occlusion test, 20 minutes was negative, 30 minutes was positive. So this kind of patient, we just need to replace the partially MCA territory. So we combine with the Silverstone clip, progressive occluded the ICA in 7 days, and combined with the STA M4 double barrel bypass. So after the bypass, you can see the stoma was all patent. And finally, this is successfully treated. So this is a type 5 ICA aneurysm with a cavernous sinus syndrome. Balloon occlusion test, CT perfusion is even good. But the enhanced balloon occlusion test, which means we decrease the blood pressure around 30%, the patient couldn't tolerate. So this kind of patient, we still need the bypass. So only need the STA, MCA double barrel bypass. This is the final result. You can see after the bypass, we completed, occluded the ICA immediately. So this is a type 6. It's a recurrent aneurysm in the distal part of ICA. You can see the acute angle reversed from the ICA to M1 and the A1. So this patient is a ruptured one, and he suffered the craniotomy several months ago. So we use original incision, and we use a radial artery as a graft. So this is intraoperatively video. You can see the patency of the radial artery bypass, and use progressive clip. So the patient was totally cured. For the MCA giant aneurysms, still the biggest challenge for the neurosurgeons, because how to protect the perforators in M1 segment was the best challenging work. So this is our strategy published in World Neurosurgery 5 years ago. So this is type 1, the ICA terminal site, terminal segment to M1 giant aneurysm. So the whole MCA blood flow should be replaced and to protect the perforators. This is a balloon occlusion test. It's positive. So this is our strategy. Use radial artery ruptured M1 aneurysm with thick wall, and it's unruptured one. So this kind of patient, we have the chance to do the distal bypass with the distal clipping of the aneurysm. So after this treatment, you can see that both bypass was all patent, and just after 1 week, the aneurysm disappeared. in CTA. So this is even distal type 2 M2 superior trunk joint aneurysm. You can see how big is the aneurysm dome. Actually, this patient, I finally reshaping the vessel cavity of the superior trunk, but it needs time, so I do the protective bypass at first. So this one, either superior trunk partially thrombosed aneurysm, so I resect the aneurysm directly, and we have enough length to do the bypass in situ end-to-end anastomose. This is even also a proximal occlusion of M1 segment aneurysm, M2 segment aneurysm with the distal bypass. Type 3, even distal part of MCA. This is the M3 big aneurysm. Also, this is the unruptured one, partially thrombosed. The aneurysm wall was so thick, so we can do the distal bypass combined with distal clipping of the aneurysm. So in this kind of treatment, MEP and the SEP monitoring is necessary. And if you have the hybrid room, that's the best choice. So we still have some complications. Sometimes it's inevitable, especially in M1 to M2 segment. There's some perforators, and it couldn't totally evitable for the delayed infarction. So we still have around 12% delayed infarctions. Although it's very small, but it can be cause paralysis. No mortality for this kind of bypass. So the normal indication for ECIC bypass is Moyamoya disease. This is a STA-MCA bypass combined EDMS. So the skin incision, bone flap, dural mat, and the targeted bypass was all individualized design. So we can use 3 layers of the ECA branch, which is the STA or post-auricular artery or occipital artery of the scalp, anterior deep temporal artery and the posterior deep temporal artery of the temporal muscle, and the middle meningeal artery of the dural. So we normally use STA or post-auricular artery or occipital artery with the MCA or ACA territory or PCA territory bypass combined EDMS. So the secret for this kind of treatment is to keep the integrity of STA, DTA, and MMA integrate. So this is how we dissect the temporal muscle. It's very fast dissecting, and this is a dural, normally flipped over according to the main branches of the middle meningeal artery. Under the microscope, you can see the middle meningeal vein normally surrounding the MMA. So the breathing for this kind of hole is quite difficult to stop. So this is how I treated. I use a gel foam strip to compress the veins bleeding, and after this treatment, you can see we protected the artery's patency and at the same time to stop the bleeding of the vein. So I call this just like a Chinese spring roll. So the stoma is located in ischemic area, but not the totally infarcted area. So sometimes the donor artery was so small, like this one is only 0.4 millimeter, but the delta P is quite high. So you can see the donor artery stand over the recipient one. After a successful bypass, you can see a red T sign in the flow 800 image, which means a high delta P. This is the SPECT. You can see the right side hemisphere after the bypass, the blood flow increased so much. And this is a long-term follow-up. You can see all the bypass, the STA main trunk, and the middle meningeal artery and the deep temporal artery. The blood flow was all increased, but the blood flow in ICA and the basilar trunk is all decreased. For this kind of patient, normally they already exist ischemic condition, so time is very important. So in my personal series, the mean temporal occlusion time is only around 30 minutes. 13 minutes, sorry. So this is how I dissect the STA from the scalp inner side. It's very fast, only take minutes. And after the harvest the STA, I close the incision of the superficial temporal fascia from inner side like this. Sometimes even 2 layers suturation, including galley. If the scalp of the STA was quite wide, you can use dural strip or sometimes the temporal muscle to fix it. So I take the simplest bypass technique. You only use 2 or 3 curved microtemporal clips, don't sacrifice any branch of the recipient artery, and never use additional rubber silicone tube or rubber mats. Interrupting suturing, square knot is enough. This is a loop technique. We choose a thicker one as a recipient artery, use 2 temporal clips and cutting off oval shape vessel wall. Then the first stage at the toe, the second one at the here. Then one side we can form the 4 loops. Cut the 4 loops, we can make 5 stitches and then make the knot separately. Another side, another 5 stitches. So totally 12 stitches. This is the ICG after the bypass. Sometimes even for the early stage Suzuki Moyama disease, we can use keyhole approach like this. This is a post-operative DSA. You can see the STA was, the parietal branch was enlarged a lot, and the bone flap was so small. So this is a 4D angiogram after the bypass. You can see the blood flow from the ECA to M2 segment. So totally replace the MCA territory. This is a CT perfusion after the bypass. So in some cases, we can almost cure the Moyama disease, but in most cases, the ICA still feeded the deep structures like thalamus and the basal ganglion. So the ICA was still functional. The latest bypass indication is the atherosclerotic cerebral ischemic. Normally, this is ICA occlusion, very long segment, so it's very difficult, couldn't be canalized by CEA or stenting. This is MCA occlusion without Moyama syndrome. This is the Moyama syndrome of MCA. Now we have a new type, stent caused the MCA occlusion. You can see the radiologist put a stent in MCA, but only after 4 months, it can cause the totally occlusion of MCA, even cause the bleeding in the basal ganglion. So for this kind of patient, simple occlusion without Moyama syndrome, we can use ST-MCA direct bypass. If the patient have a Moyama syndrome, we still combine the EVMS. So this is a combined approach. You can see the STA enlarged a lot, double barrel bypass. But at the same time, the middle meningeal artery and deep temporal artery also feed the indirect bypass. So this is a 4D angiogram after the bypass. Now with we use a TASL sequence, we can tell which territory was fed by ECA and which territory fed by the ICA. So I designed this new set of single-eye microanastomos instruments. So this is a video to use micro clips and the micro needle holder. You can see I designed the tip of the micro instruments wider than the original ones, the classical ones. So so the risk of cutting the suture is less risky. So the bypass technique is not a dying art. The ischemic brain can be revascularized. The simplest bypass technique is easy to learn by residents. So you can see this is in Indonesia in this June. We have an anastomos workshop with Professor Asra and Luis Boba. Thank you. This is all my report, and this is my email. If you are interested in anastomos technique, you can visit us in the future. Thank you.
Thank you very much, Professor Bean, for this outstanding lecture. I'm afraid that due to time restraint, we cannot go on to discussion, so we need to go to the next session. Thank you.
Okay.